Also at this meeting, I'll be presenting some data on the use of checkpoint blockade inhibitors to treat relapsed hematologic malignancies after allogenic stem cell transplantation. This is a very challenging area because patients have limited treatment options and overall survival is typically poor in the range of 6 months or less. So we previously published an article showing that ipilimumab, given at 10 milligrams per kilogram, can induce responses in patients with lymphoid and myeloid malignancies in this specific patient population. So in my oral presentation at ASH this year, I'm updating that original study data set to show the long-term follow-up for these patients from the original cohort. And what we found was a fairly striking finding, which is that the median overall survival for our group is 28 months, significantly longer than what we expect for patients treated with traditional therapies. And some of these responses have now been durable for 3 to 4 years since their initial dosing on ipilimumab. However, one of the issues with the 10 milligram per kilogram dose was that we did see some immune-related toxicities and some graft versus host disease. So in my presentation, I'll also present for the first time some data on a lower dose of ipilimumab, 5 milligrams per kilogram, where we tried to see if the lower dose may preserve the efficacy while lessening the toxicity. Unfortunately, we still saw a fair amount of toxicity at 5 milligrams per kilogram, and the efficacy data looked a little bit less than what we saw at 10 milligrams per kilogram. So our preliminary conclusion from that is that it probably makes sense to dose at 10 milligrams per kilogram of ipilimumab going forward. Also in this study, we explored for the first time the use of PD-1 blockade with nivolumab for patients who relapse after allotransplant. There's been some very important recent reports in the literature that are retrospective studies suggesting that although patients with lymphoid malignancies can respond well to this approach, there's a substantial risk of graft versus host disease, particularly in patients who have previously had GVHD. Our study is the first prospective data for PD-1 blockade in the post-allo setting. And so far, we started at a dose of 1 milligram per kilogram, and we also saw some significant immune-related toxicities there. So we dose de-escalated to 0.5 milligrams per kilogram, and we've treated 8 patients at that dose so far, and the preliminary results do look promising with less toxicity, and we are seeing some responses, primarily in lymphoid malignancies so far. We haven't seen the types of myeloid responses that we saw with ipilimumab, but the data are still early, and we're going to be opening an expansion cohort for our nivolumab study of 15 additional patients, and I think that'll help us to tease out whether there is an efficacy signal there for this approach.